Hey there, I'm Professor McBride, labor nurse, OB instructor, and your guide to everything OB. Let's get to it. Let's practice what we know about postpartum hemorrhage. A new mother has saturated 2 pads in 30 minutes and has a boggy uterus. Which action should the nurse implement first? A. Have the client empty her bladder. B. Inspect the perineum for lacerations. C. Perform fundal massage until firm. And D, increase the oxytocin IV infusion. The best answer for this question is C, perform a fundal massage until firm. The mother is showing signs of postpartum hemorrhage because she saturated 2 pads in 30 minutes, and then she also has a boggy uterus. Uterine atony is the primary cause of postpartum hemorrhage in the first 24 hours, which means the uterus is not contracting well. And so we needed to contract and squeeze to compress the vessels that used to feed the placenta. So the first thing we need to do is massage the fundus and try to make it contract and become firm and stimulate that contraction to reduce the bleeding for the patient. If we have her empty her bladder, the bladder is a good thing to also consider. We need to massage first, but a full bladder can put pressure on the uterus and decrease the contractility. So managing the bladder is a good second thing to think about. We also can evaluate to see if the uterus is displaced, because if it's not in the midline, if it's deviated, or if it's rising up in the mother's abdomen, those can be signs that the bladder is full. And so we can assess the bladder and we can empty the bladder, but not before doing uterine massage. We can also inspect the perineum for lacerations. If this mother's uterus was actually firm, then the next place we would think about where her bleeding could be coming from would be an unrepaired laceration. So if the uterus is firm, then it could be that. In this situation, that's not the best choice because her uterus was boggy. And then increasing the oxytocin infusion is also something that could be considered to help encourage the uterus to contract, but the nurse's first action is still going to be fundal massage. Question number 2. The nurse is monitoring a postpartum client who is bleeding for signs of shock. Which indicates an early sign of shock? A, an increase in pulse rate from 88 to 122 beats per minute. B, complaints of abdominal cramping. C, a blood pressure change from 130/88 to 124/80 millimeters of mercury. Or D, the fundus is at the level of the umbilicus. For this question, the best answer is A, an increase in pulse rate from 88 to 122 beats per minute. Tachycardia, or an increased heart rate, is typically the earliest sign of shock for a patient experiencing excessive blood loss. The body tries to compensate for that reduced blood volume, and so it starts pumping the heart faster to circulate the remaining blood and keep the oxygenation going to the organs. So if we see an increase in heart rate, we see tachycardia, that is really a good sign that we need to evaluate further for hypovolemia or bleeding. Choice B said complaints of abdominal cramping. Abdominal cramping is not an early indicating sign of shock. It is actually something that's normal in the postpartum period. As the uterus contracts to control bleeding, she might experience cramping. A blood pressure change of 130/88 to 124/88 millimeters of mercury. Blood pressure can decrease as blood volume goes down, but this decrease in blood pressure is considered a late sign of shock, not an early sign of shock. So we see tachycardia before we see hypotension. Plus, this change is not significant and not significant enough to be concerned about hypotension for this patient. The fundus at the level of the umbilicus, that's actually where we expect to find the fundus, and this is also not a sign of shock. If she has uterine atony and if she's bleeding, sometimes the uterus can be enlarged and be above the umbilicus, which we might see, but this wasn't a good choice for this question. So different signs if we have postpartum hemorrhage could be the tachycardia. We could also see hypotension as a late sign of shock, as we discussed. We could see pallor. We could see cool, clammy skin. We could see confusion. We could see decreased urinary output because she's not perfusing her kidneys well. But most of those are still going to be later signs. Tachycardia is going to be the first. Question number 3. After a precipitous delivery, a client has bright red blood trickling from her vagina, a firm uterus, and tachycardia. What could cause this? A. Late postpartum hemorrhage. B. Vaginal laceration. C. A full bladder. Or D. This is the expected course in the 4th stage of labor. So the best answer here is B. Vaginal laceration. If she's having a bright red trickling of blood and the uterus is firm and we have tachycardia, we have signs of hypovolemia because we have tachycardia, we have a firm uterus. So the first thing if we see blood is to evaluate her uterus. And so her uterus was firm. But if we're still seeing this bright red trickling, so this definitely could be a sign of a laceration. So especially having had a precipitous delivery, this definitely increases the risk of having a laceration as well. So answer A was late postpartum hemorrhage. Late postpartum hemorrhage occurs days or weeks after the baby's born and typically is caused by either retained placental tissue or infection. So that's not the correct answer. A full bladder. A full bladder could cause bleeding, and it typically could lead to that deviated from the midline uterus, and also then could cause uterine atony. So then the uterus would feel soft and boggy, which was not how this patient presented. And then the other option was D, an expected course in the 4th stage of labor. And while some bleeding is normal and we expect lochia rubra, we definitely do not expect this red trickling that is continuing to happen, and also the sign of tachycardia, which is a sign of hypovolemia for our patient. So concerning signs with an early hemorrhage, if they're saturating more than a pad an hour, if they're passing clots bigger than teeny tiny small ones like the size of a dime or a nickel, if their fundus is boggy, then it's probably uterine atony. If they have the constant trickle but the firm fundus, it's probably an unrepaired laceration. And if they don't have blood on their pad, but we're seeing signs of hypovolemia, like if we're seeing tachycardia, and also if she's having a lot of perineal pain and pressure and swelling, that could also be hematoma where she could be losing blood into that. So we have to, for early hemorrhage or bleeding in those first 24 hours, we have to remember our 4 T's. Tone, which is uterine atony. Tissue would be if she had retained placental fragments. Trauma, which is our lacerations, and then thrombin is another T that we consider, which would be a coagulation issue. Question number 4. 2 hours post-delivery, the fundus is 3 centimeters above the umbilicus and deviated to the right. The nurse suspects bladder distension. What can bladder distension cause postpartum? A. Bladder wall atony. B. A ruptured bladder. C. Urinary tract infection. Or D. Excessive uterine bleeding. The best answer for this is D. Excessive uterine bleeding. So if the bladder is full and it puts pressure on the uterus, then it's going to cause the uterus not to contract well, so it can lead to uterine atony. And so what we can see on assessment is we can see that the uterus that may have been midline at the umbilicus where we expect it to be after delivery is now deviated to the left or right, typically to the right, and then elevated above where we were finding it before. And so in this question, we were 3 centimeters above the umbilicus and deviated to the right. Those are all classic signs of bladder distension, and a big concern will be bleeding. So the other choices for this question were A, bladder wall atony. While the bladder is distended, the primary, immediate, and most severe consequence affecting maternal safety is the impact on the uterine contraction, not the bladder wall itself. So that wasn't the big concern for this patient in the moment. B, a ruptured bladder. So this is very rare. And again, the immediate concern is still going to be the hemorrhaging that can happen if the uterus isn't contracting. And then C, a urinary tract infection or UTI. So UTI is a potential long-term complication, and this would be something that we could consider down the line. But again, the most immediate concern is going to be the fact that we have a fundus that's elevated from the umbilicus, it's deviated, and these are all concerns that can cause uterine atony, which will lead to bleeding. Question number 5. A nurse is caring for a client who has just delivered a baby and is experiencing postpartum hemorrhage due to uterine atony. Which of the following medications should the nurse anticipate administering? And this is a select all that apply question. So A, Methergine, B, magnesium sulfate, C, Hemabate, D, oxytocin, and E is misoprostol. So for this question, all of these medications are considerations except for magnesium sulfate. So all of these medications, Methergine, Hemabate, misoprostol, and oxytocin, are all drugs that are called Uterotonics. So they encourage uterine tone, or they encourage the uterus to contract, which will reduce bleeding. They all act on different receptors of the uterus and have different side effects and contraindications depending on the medication. So which ones to use are going to be dependent on your patient and what her comorbidities are, how she's clinically presenting, and things like that. Magnesium sulfate was the other medication listed as a choice for this. Magnesium sulfate is actually a medication that has a tocolytic effect, which means it can relax the uterine muscle. We use it for preterm labor to try to slow contractions down, and we also use it as a medication to prevent seizures with preeclampsia. It is definitely not a medication that we're going to use to help with postpartum hemorrhage. It actually could worsen uterine atony. And so a patient who's on this medication for other reasons, we have to monitor their uterus closely. So when we think about postpartum hemorrhage, atony is the #1 cause in the first 24 hours. And so we need to massage the uterus, we need to manage the bladder, and then we need to consider our medications. And so those medications were the ones from that question. So Pitocin or oxytocin, Cytotec, which is misoprostol, Hemabate, and Methergine. Question number 6. Methergine is prescribed for postpartum hemorrhage. Before administration, the nurse notifies the MD of which condition? A, diabetes, B, asthma, C, hyperthyroidism, or D, hypertension? For this question, the best answer is D, hypertension. So Methergine is a vasoconstrictor, so it causes the blood vessels to narrow, which can increase blood pressure. If your patient has hypertension or if she's preeclamptic, she should not have this medication because it can cause serious cardiovascular complications for her. It's possible during a hemorrhage that your patient isn't currently hypertensive, but if she has been hypertensive prior to becoming hypovolemic, we still would not consider this medication for this patient. So the other options for this, A was diabetes, and this is not a contraindication for Methergine. B was asthma. Asthma is a contraindication for a different postpartum hemorrhage medication, which is Hemabate, because Hemabate can cause bronchospasms, but it's not a contraindication for Methergine. And then C, hyperthyroidism, and that's not a contraindication either for Methergine. Question number 7. A nurse is caring for a client who's experiencing postpartum hemorrhage as a result of uterine atony. The nurse understands that this means A, the uterus has torn during delivery, B, placental parts remain in the abdomen, C, the uterus is contracted too much, or D, the uterus fails to contract after delivery. The best answer for this question is D, the uterus fails to contract after delivery. So with uterine atony, atony means the absence of tone, atonic or atony, okay? So after delivery, the uterus is supposed to contract and compress the blood vessels where the placenta was attached. And if that does not happen, these vessels can bleed freely, which can cause the hemorrhage. And a woman can lose a large amount of blood volume through her uterus in a matter of minutes. Other choices that were listed for this question: A, the uterus is torn during delivery. A tear or laceration could cause bleeding, but it's different than what we see with postpartum hemorrhage from Atony. B, placental parts remain in the abdomen. So retained placental fragments can prevent the uterus from contracting, but they wouldn't be in the abdomen, they would be in the uterus, and then it could cause atony. Or C, the uterus is contracted too much. That's the opposite, okay? The uterine atony is characterized by a uterus is contracting too little. Question number 8. A client who is 10 days postpartum calls the clinic reporting that her vaginal bleeding, which had been tapering off, has suddenly increased. She said she has passed several large blood clots and feels weak and lightheaded. What is the most likely cause for these symptoms? So each of our practice questions up until now were really focusing on early hemorrhage and bleeding in those first 24 hours and uterine atony. We can see this patient is 10 days postpartum, so now we're going to be thinking about late hemorrhage. So keeping that in mind, choices were A, early postpartum hemorrhage, B, endometriosis, C, retained placental fragments, or D, this is part of the normal involution process. The best choice for this question is C, retained placental fragments. So if we have a secondary postpartum hemorrhage, so this is something that's occurring after the first 24 hours up to 6 weeks after delivery, the most common causes for this are going to be either retained placental fragments that are in the uterus keeping it from contracting properly, or possibly an infection like endometriitis. So the other choices were A, early postpartum hemorrhage. This is what happens in the first 24 hours and is often due to uterine atony. So 10 days, we are in the late hemorrhage time. B, the choice was endometriosis. So infection of the endometrium called endometriitis can cause a secondary hemorrhage. The endometriosis is an inflammation of the uterine lining and isn't a primary cause for this sudden heavy bleeding that this patient is experiencing. So this is usually going to be retained placental fragments or infection that causes this. And then D, normal involution process. If we're having lochia that has switched back to red bleeding, that's not normal. The normal process should be lochia rubra, which is red for the first few days, switching to serosa, which is the pinkish, mucusy, maybe a little bit brownish, and then switching to alba. And so if we regress back to red bleeding, that's a sign of postpartum hemorrhage, like a late postpartum hemorrhage. So with late postpartum hemorrhage, we have subinvolution. So the failure of the uterus to contract and return to its prepregnant state. Retained placental fragments and infection are the main causes. If we have delayed lochia, return to rubra, excessive bleeding, enlarged uterus that is not contracting back down, those are all signs. And so treatment is typically going to be medications to help the uterus contract, maybe antibiotics, and they might have to do a D&C where they go in and actually clean out those retained fragments from the uterus. So to do a recap, postpartum hemorrhage causes maternal mortality. Early hemorrhage's #1 cause is uterine atony. What we need to do is to massage the fundus, manage the bladder, give our medications. So our Uterotonics are going to be our medications that make the uterus contract. Pitocin, Cytotec, Hemabate, and Methergine. And then we're also assessing for managing hypovolemia. With late hemorrhage, this is typically caused by subinvolution or the uterus's inability to return to its prepregnant state. She might need a D&C in order to resolve it. Thanks for watching. Be sure to subscribe, like, and share for new videos every week about everything OB. See you soon.